It's great to be here at the North Shore Chamber. It's great to be with a lot of friends. Bob is such a leader in the healthcare field, both here in Massachusetts and actually beyond our borders. Got to know Bob Bradford from the Chamber, and I thank you for including me today. Other great friends and collaborators in the audience, especially Howard Grant, who leads one of the most significant health systems regionally in the state and has brought a lot of innovation with him when he came here from Pennsylvania. And it's nice to see old friends like Jerry McCarthy, because Jerry and I worked together when we both had dark hair. And so it's nice to have someone with a little history with me and know there was a different person. So Bill's right, we have a significant presence, Blue Cross in the North Shore. Although we are headquartered in Boston, we count 2,700 employers as our customers in the North Shore, employing several hundred thousand people, and so we feel embedded in the community. Many of our own associates at Blue Cross live in the North Shore. It's not just the governor, the secretary at A&F, and secretaries of community development who live in the area. And then we're committed from a community perspective. Our not-for-profit foundation and our corporate citizenship programs have contributed just about $1 million. There's another old friend over there, hi Paul Zikos, contributed $1 million to North Shore communities over the last 5 years. So we feel part of this community. But what I want to talk to you about, I really do want to take up the challenge that was issued this morning. I want to talk to you about 3 actions that I think we need to take as a community, as a healthcare system, to reshape how we think about healthcare, how we experience healthcare, both here and around the country. And there are these 3 things, 3 actions we need to take that I think will be transformative. First, we need to reorganize healthcare around the needs of patients and consumers, and not so much around the needs of organizations and institutions like Blue Cross, North Shore Medical Center, and Leahy Health. Second, we need to fundamentally change the way we pay or reimburse for healthcare. And third, we need to turn the tide on chronic illness. Taken together, these 3 actions have the potential to put us within reach of what I think of as the holy grail in healthcare: higher quality at lower costs, not bankrupting anyone here in Massachusetts. Now, we start with a very strong foundation in Massachusetts. We're lucky. We have nearly universal coverage, something no other state can say in the nation. We have this extraordinary network of academic medical centers, community hospitals, physician groups, other clinical organizations, many right here on the North Shore. We have the highest rated health plans, not just Blue Cross, but some of our competitors, Harvard Pilgrim, Tufts, and Fallon, very high quality plans. And we're the first state in the country to actually, where the state government said, establish a cap on the amount of healthcare spending can grow in the state. And this cap is needed to be implemented part with government regulation and part with innovation from the market. But as Bill suggested, we have a long way to go. Healthcare costs continue to be a burden for individuals, for companies, for employers and government. They're eating into family budgets, they're eating into business competitiveness, and they're crowding out other public priorities. We can and we must do better. So how are we going to solve this affordability problem together? Well, I believe if we take these 3 actions and actually deepen and accelerate them, we can actually get within our grasp this holy grail of better quality and lower costs. So let me talk about each briefly. So the first thing is we need to reorient our system around the healthcare needs of consumers and patients, and again, not around the needs of institutions. So think about this scenario for a second. Many of you have been in it. You have some health concern. You go to see your primary care doctor with this medical issue. Your PCP says, you know, as I look at this, I really want you to see a specialist. You go to the specialist who says, I think I know what's going on here, but I think you need a few tests to confirm it. At each step, at the PCP, at the specialist, at the test or procedure, you have forms to fill out, almost always still on paper, questions to answer. Then when it's time for the procedure itself, where should you get it? How do you know it's the best place for that procedure? What is it going to cost? And then the insurance side of the equation comes in. You want to know, is it covered? How much you're going to have to pay? You heard about these newer higher deductible plans. What's your responsibility? What is the health plan's responsibility? What is the deductible or the copay or the coinsurance? And then eventually you get that really helpful statement in the mail that says, this is not a bill, that you all look at. And you say, you know, okay, what am I supposed to do with that? Well, imagine a very different experience. Okay, you're in Barcelona, Spain, or Amsterdam, and you need some local currency. And it's 10 o'clock at night, but you can go to an ATM machine, you can take out cash in the local currency. It'll tell you your balance back here in Danvers or Salem. And then when you get back to the hotel, you can go online, book a tour of the city for the next day, and pay with your credit card. It's all simple, it's transparent, the technology is accessible, it's easy to use, and it's designed to meet your needs anytime, day or night. Why not in healthcare? Why has healthcare resisted that kind of easy interaction? Well, the fact is we're a complex, fragmented business that's out of step with what consumers expect and demand in many other aspects of their lives, especially when their money or their well-being is at stake. And that has to change. So imagine for a moment, you're on your smartphone, there's an application on your phone that takes you step-by-step decisions about your care with cost, quality, and outcome information. I mean, Howard likes to tell me on a regular basis, meaning every time I see him, that he is the high-value provider in his market. I think Bob would tell me the same thing. And they are both superb institutions and friendly competitors. But wouldn't you like to know that if you had to have your foot operated on, that you knew what's the record of the surgeon? How often have they performed it? What am I going to pay when I get there? And that in addition to that online information, there was a phone center where you could call and ask further questions. How about if you went to a lab or a specialist office and when they scanned your Blue Cross card, which by the way would probably not be in your wallet, but actually right there on your smartphone, and it could immediately tell you how much is this going to cost, how much will apply to your deductible, how much will be billed later, and maybe the whole financial transaction can happen right there. What if rather than getting that inscrutable, this is not a bill statement, you got a nice clean monthly statement from your health plan that told you exactly what your insurance paid, exactly what you're responsible for paying, and at the end of the year you got a summary statement, an annual statement with a complete overview of your coverage, your out-of-pocket costs, with tips how you might reduce your expenses for the next year. Creating this kind of healthcare experience won't be easy, but it's a vision at Blue Cross we're committed to delivering. In fact, we've already gotten started. We're starting to reinvent our business to deliver a new kind of consumer experience. Guided by our promise to always put our members first, we're examining virtually every aspect of our business to ensure that we're in step with what contemporary healthcare consumers need and demand. Our members don't just want us to solve our problems. There was a time, call us up on the phone, take care of my problem, and we're done. Today they want us to simplify their experience, anticipate their needs, and engage with them on their terms, So let me give you an example. In recent years, there's been a growing interest in what we call consumer-directed health plans, which have higher cost sharing for members and also a health savings account that employers can help fund, individuals can use to pay for some medical expenses. As the head of HR for one of our major employer customers put it recently, and I quote, "Consumerism means employees are asked to consider all their options when choosing health care, just as they are when they're making any other important purchase." But all this is new to most of our members. So we took a step in the membership process to figure out what would people really need to know, when and how, what do they want to know. And now at key points, when our members are signing up for these new consumer-directed plans, when they get their first ID card, when they have their first healthcare experience that generates a claim, we're actually calling them up to explain to them, here's how your coverage works. Do you have any questions? Do you know what you're personally responsible for? Because some of our customers sign up for these new plans and then their employees aren't really educated. It's not high tech yet, but it's personal, it's relevant, and it meets the mandate to simplify, anticipate our members' needs, and engage with them on their terms, not just wait when they have a serious problem. We're also moving quickly to adopt and evaluate mobile apps and web programs that get people engaged in their care, from support for weight management and exercise tracking to help controlling diabetes and other common conditions. Developing these new tools and technologies take time, of course, and there are legitimate concerns about privacy and security and confidentiality, which we take very seriously. But I think we have reason to be optimistic about the ways that personal technology on our phones, laptops, and tablets could make healthcare much more responsive to the needs of patients. But there's a catch, because the traditional way we pay physicians and hospitals in our country works directly counter to our desire to be more flexible, more innovative, and patient-centered. So that gets to action number 2 we need to take, and that's we must change the way we pay for healthcare in the state and in this nation. For 75 years, we've been paying one way for care. It's called fee-for-service. We pay for activity, for a visit to a physician, for an admission to a hospital, and for every test and procedure, and we pay even more if the test or procedure are more complex or technologically intensive. We pay for the amount of care without any recognition of the quality or the outcome of the care. Imagine for a second, there's a primary care practice at North Shore Medical Center at Leahy Health, and they're doing such a good job managing a Blue Cross patient who has a chronic condition like congestive heart failure that they're able to keep the patient out of the hospital for the entire year. What's their reward at the end of the year? We pay them less. Now imagine the opposite experience. They don't do a very good job. They don't follow up with the patient. They don't make sure they're getting the proper preventive care. And the patient actually gets admitted to the hospital, maybe multiple times. What's the result? We pay the hospital more. And imagine actually if they're in the hospital and they're unfortunate enough to contract an infection, we pay more again. Now, doesn't that seem backwards to you? Shouldn't we be paying more for better results, for better care, for better outcome, as opposed to just for activity? So that's what we challenged ourselves to do. About 7 years ago, we designed a new way to pay for healthcare. Bob mentioned it. We called it the Alternative Quality Contract. If we ever knew how it would have taken off in this state and become a model for the nation, we would have called it something different, like Blue Sky or Blue Breakthrough or Blue Innovation. Everything in Blue Cross is blue. You want to take your employee, you take a course, you go to the Blue Campus, which is just an online course, everything's blue. But we called it the Alternative Quality Contract, and by the time we tried to change it, we sent it to our marketing department, it was too late, it had stuck. Everyone knew it, and in the healthcare community, they even knew its acronym, the AQC. So under this model, rather than giving physicians and hospitals incentives to do more, we give them incentives and data and the support they need to perform at their best for their patients. We pay them more when they elevate quality and produce better outcomes. Today, 85% of the primary care physicians and the medical specialists in Massachusetts participate in this model, many of them, I would say, enthusiastically, including most of the practices here on the North Shore, and it's working. Independent researchers from Harvard Medical School examined the first 4 years of this new program. It's the most studied payment reform program in the nation, and they found that it lowered cost and improved care for our HMO members. That study was published just 2 months ago in the New England Journal of Medicine, the most prestigious medical journal in the world. Now, by 2016, we want to expand this program beyond just our HMO members to also cover our members who select PPO products and Medicare Advantage as well, and I know some of our hospital partners are enthusiastically awaiting that development. So what happens when you unleash the creativity of physicians and hospitals and you take them out of this old fee-for-service activity-based system and put them in a system that rewards quality and keeps them from just spinning and spinning and spinning? What they do, they redesign care, they improve care around the needs of their patients, around the needs of their patients. In some areas, in some physician practices, what have they done? Noticing that many of the patients, the medical problems also are connected to mental health problems. Some of the physician practices are hiring social workers and embedding them right there in the physician practice so that they can deal with the mental health or psychiatric problems immediately. Some are collaborating with emergency departments. I visited in the Merrimack Valley a physician practice, and they said orthopedic surgeon, he said, in the old days, I get a call from the hospital and say, one of your patients is here, he sprained his ankle. And the surgeon would say, well, do the test, admit him, and I'll see him in the morning, we'll decide what to do. Well, that was the old system. Now that he has financial accountability for this patient, what does he do? He drives to the emergency department, he evaluates the patient right there, and he says 60% of the time, the patient doesn't require an admission to the hospital. It's a new way of taking care of patients that's better for patients and lowers costs. Other programs have set up special care management programs for some of their most expensive patients who have multiple chronic illnesses to identify gaps in care and develop care plans to keep people healthy and, if possible, stable and out of the hospital. Which brings me to the third action or intervention I want to talk to you about today that I think will help us transform care, and that's to turn the tide on chronic illness. We have a lifestyle epidemic in the United States. Diabetes, heart disease, obesity, all on the rise. 3/4 of chronic disease is linked to lifestyle risks and behaviors like poor diet, little exercise, or tobacco use. At Blue Cross, 5% of our members account for 50% of our spending, and 1% account for 20%. And I'll make a little prediction here that you may hear that same statistic in the inaugural address tomorrow from Governor Baker, because he knows it and he talked about it in the campaign. So 5% account for 50% of our spending. Yes, there are a few organ transplants in there, or very expensive premature babies, or major trauma, but most of those 5% are people with multiple chronic illnesses. They have diabetes and heart disease. They have cancer and depression. And it's those multiple comorbidities, as we call it in healthcare, that's driving the costs. If we can intervene earlier and help people take better care of their health, there's a much better chance they'll stay out of that 5% and lead a much fuller life. So to help turn the tide on chronic disease, we're collaborating with our members, our customers, and physicians and hospitals on new approaches to wellness, disease management, and focusing less on what happens in the physician's office, as important as it is, and more on what happens in people's home, in their workplaces, and in their neighborhoods. Many of our employer customers are investing in workplace wellness programs designed to reduce health risks, help their workers lead healthier lives, and over time contain healthcare costs and increase employee retention and productivity. Here on the North Shore, employers of all sizes and types are investing in health, including many of the cities and towns covered by Blue Cross through MIA, the Massachusetts Interlocal Insurance Association. Now, each year we give out something called Municipal Blue Innovation Awards to recognize the most innovative and successful worksite wellness programs and cost containment measures that are being used by cities and towns. And I'm pleased to announce that one of our 2015 awardees is right here in the room, right here at the head table, and that's going to be the City of Newburyport, where Mayor Holliday and the Public Employee Committee worked together on a very creative 2-year agreement that stabilizes health cost increases and introduces some new programs. Other recent Municipal Blue Innovation Award winners here have included Amesbury, Saugus, Beverly, Peabody, and Wakefield. All of these communities have made wellness a key component of their healthcare strategy. In Newburyport, for example, the city worked with MIA to create a strong employee-based wellness committee. It's called Team Newburyport, with representatives across city departments and municipal unions. The team meets monthly to discuss wellness programs, ideas, and ways to create a healthy work culture. It's a relatively new initiative, but I understand one of the highlights last fall was a pedometer walking challenge between the schools and the mayor's office that brought out a couple hundred participants. The mayor explained to me that it was kind of hard because she had it with the school superintendent. Turns out school superintendents do a lot more walking than mayors, so I think she lost out on that personal challenge, but they were doing the right thing for the community. Another great example of employers investing in health is the Banking on Wellness program that we have with the Mass Bankers Association, created a few years ago. The program focuses on educating bank employees about their health risks and then giving tools for them to take action, such as eating healthier, being more active, and losing weight. More than 100 of the association's member banks purchased Blue Cross medical and dental insurance through our group trust, and 12 of the 92 banks are now participating in this Banking on Wellness, and those 12 of those are located here on the North Shore. Employees can earn points for completing online health assessments and at least one wellness activity during the year. And each month, employees who earn points are entered into a kind of a gift card a raffle. The wellness activities include online nutrition workshops, weight management, stress management, health education seminars, and team-based challenges like in Newburyport. And employees at the North Shore banks that participated in team step challenges held just last fall accumulated 18 million steps, or 8,600 miles. This is new activities that these bank employees committed to. So those are some of the ways we're working with our customers to reduce the risk of lifestyle-related chronic illnesses. But what about our members who are already chronically ill, and there are many? Well, in addition to the great work done by our physician partners and our hospitals, we at Blue Cross have our own team of nurse case managers who reach out to these members, identify gaps in their care, coach them on healthy lifestyles, and connect with their own physicians and social service professionals. So in one case recently, we worked with a 52-year-old member who had coronary artery disease, high cholesterol, and pulmonary disease. He had just suffered a mini stroke, and he was forced to go on disability. One of our nurses, he was identified as a high-need patient. One of our nurses reached out to him, found out that in addition to his medical problems, he was depressed due to these issues. He'd also been recently had some deaths in his family. He was out of work, and he actually even lost his treasured, long-standing companion of a dog. He wasn't using his inhalers, which were critical to his pulmonary disease, and he had let several of his prescriptions lapse. So our nurse began working with him for several months, got him back on his medications first, followed up with his physicians, making sure he was keeping his appointments. She started providing support to get him to quit his 2-pack-a-day smoking habit and help get him on a healthier diet. He also became more active. As he became more active, and he got a new dog, and then they started walking every day. And he recently told our nurse coach that he felt better than he had in years. And he said he realized that he had to take control of his own health, but he needed that push. He needed that guide. He needed that coach, and he couldn't have done it without her. This case shows how complex medical and mental health issues are often intertwined, especially for people with multiple chronic conditions. And we've developed at Blue Cross a highly coordinated approach so that we can bring medical and mental health care management together to improve the quality of life in our members. So this is an environment where things are changing fast, rapidly, but I believe if we take these 3 actions, if we reorient our healthcare system around the needs of consumers and patients, if we pay differently for healthcare, and if we focus on both treating and preventing chronic illness, we can have the kind of healthcare system that we want and at a cost we can afford. But I want to just conclude with a note of caution, and it has to do with some of the astonishing advances in medicine that we're hearing about every day. Medical researchers are developing therapies, technologies, and drugs that were unimaginable a few years ago. We're going to want all of them for ourselves and for our families, our workers, and we'll want health insurance to cover them. But they come with very high price tags. One example that's been in the news lately, some of you may have read about, is a new drug called Sovaldi. It offers a 90% cure rate with very few side effects for hepatitis C, a disabling disease that affects almost 3 million Americans. But this new drug cost $84,000 for a 12-week course of treatment, or $1,000 per pill. At Blue Cross, our spending on these kind of what we call specialty medications, Sovaldi is just one of many, increased by 30% last year. Specialty medications account for only 1% of all prescriptions written, but account for 1/3 of our annual pharmacy spending, or about $500 million. So we're spending $500 million on this 1% of medications. And many more breakthrough therapies are in the pipeline. Some of these interventions are actually going to be designed, custom designed for your DNA, for your genetic makeup, and as a consequence have great promise for cures and treatments, but great promise for very expensive treatments. Now, the cost of these treatments are going to place a great burden on public and private payers, and back to the introduction, that is part of the challenge. And in today's environment, given the increases some of us have experienced over the last decade, they're simply unsustainable. And we're going to have to ask some very difficult questions about the price, the effectiveness, the value of these new interventions. But I believe if we unite as a community behind these 3 interventions I've discussed today, organizing care around the needs of patients, changing how we pay for care, and turning the tide on chronic illness, I believe we can actually take a lot of unnecessary spending out of the system, which will liberate funds to pay for the best of the new treatments and have the kind of care we want and need. I'm proud of the role that Blue Cross has played as a leader and an innovator during this period of great turmoil and change in healthcare, but we're only part of the puzzle. So sustaining and building on the progress in Massachusetts will take persistence from all of us, from consumers, from employers, from physicians and hospitals. We have so many of the pieces in place. We can have, I believe, high quality care, the health care we want, at a price we can afford. Let's make it happen together. Thank you very much.